Yes, sir. Miss X, 35-year-old, complains of palpitation 7 years and breathlessness 6 years duration.
So what do you make out of that?
There is 7 years history of palpitation and 6 years of breathlessness. The chronic condition. It can be some arrhythmias, thyrotoxicosis, valvular heart disease may be there, sir. Valvular heart diseases.
So what are the mechanisms of palpitation?
Palpitation can be due to atrial fibrillation or increased volt, that is tachycardia, then
Altered rate, altered rhythm, or altered force of contraction.
Yes, sir.
Okay, so this patient has got palpitation. Can you tell some situations where you have palpitations?
Yes, sir. In mitral stenosis, complicating atrial fibrillation.
So arrhythmia,
Yes,
okay.
Yes, sir. In thyrotoxicosis, there may be palpitations.
That's good.
Then anxiety.
That's okay.
Yes, sir. Then volume overload conditions.
So palpitation may be because of volume overload. Good. So what's the second complaint of this patient?
Second complaint is breathlessness.
Okay. So what do you want to know?
Breathlessness may be respiratory cause or cardiac cause. We have to get
Can you have
differently. Yes, sir.
breathlessness due to abdominal problems?
Yes, sir. Abdominal problems.
What?
Peritonitis. It will be very difficult. In ascites, the diet will be upwards.
Ascites. Okay.
Yes,
so can you get breathlessness in anemia?
Anemia. Yes, sir. It's possible, sir.
So how do you analyze the history of this patient? What all details you want to know now?
Yes, sir. Any childhood?
The first step,
yes, sir.
First step is to know what's the mechanism of palpitation. Second is to know what's the cause of breathlessness. Carry on.
Yes, sir. Yes, sir. We have to any childhood infections or childhood long-term intake of antibiotics.
Right.
We are suspecting a rheumatic heart disease, so we have to ask about the history. We have to ask about increased thyroid features, hyperthyroid features,
right?
Like any weight loss or irritability, increased sweating or diarrhea, then anxiety features, anything. Then yes, sir. Then about the breathlessness.
Right.
Breathlessness, we have to ask about whether there is any lying down position increasing breathlessness or breathlessness during sleep. Patient wake up during sleep and walking towards the window after 4 hours of sleep. And is she gasp for air during sleep? These are asked to check whether there is any cardiac problem in this case.
So here it is.
Yes, sir.
With more details are available.
Yes, sir. Here palpitation on exertion only. There is a regular rhythm. Then dyspnea grade 2 to start with. Then now it is grade 3. Then occasionally wake up 1 hour after going to sleep. One episode of hemoptysis is also present.
So palpitation on exertion alone, what does it mean to you?
Sir, it is cardiac.
Possibly it is not related to any arrhythmia.
Yes,
which
sir.
will occur even at rest.
Yes, sir.
So, second is it is regular palpitation, again not favorable to any arrhythmia.
Yes, sir.
What does dyspnea indicate to you?
Dyspnea indicating pulmonary congestion.
The dyspnea points to the progressive disease.
Yes,
To
sir.
start with was grade
Yes, sir.
2, now it is grade 3. What is grade 2, what is grade 3?
In grade 2, there is a slight limitation of physical activity only. Ordinary, the patient will be comfortable at rest.
Grade 3 is?
Grade 3 is there is limitation of physical activity is there. Then in activities less than the ordinary activity causes breathlessness.
Are the breathless at rest?
No, sir.
Okay. Anything else can you make out from the history?
Sir, occasionally wake up after 1 hour going to sleep.
What is it?
That is called paroxysmal nocturnal dyspnea.
What does it indicate to you?
It indicates left heart failure.
Left heart failure. So can this be bronchial asthma?
Bronchial asthma, no, sir.
Why?
In bronchial asthma, there is no, after going to sleep, then exertion is possible, sir. Then
Bronchial asthma patients usually have problems of breathing early morning.
early morning, sir.
Cardiac patients usually wake up soon after going to bed.
Yes, sir. Then bronchial asthma people, they may be affected with right heart failure long term, not a left heart failure.
Bronchial asthma patients do not have any exertional breathlessness.
Yes, sir.
It's a breathlessness unrelated to exercise.
Yes, sir.
Then carry on.
Yes, sir. Then one episode of hemoptysis is also present, sir.
What can be the cause?
Due to pulmonary congestion, pulmonary capillary rupture,
Due to what?
due to increased pulmonary venous congestion.
So pulmonary
Venous pressure will be increased.
hypertension.
Yes, pulmonary arterial hypertension will be there.
Pulmonary hypertension is the number one cause. There are
Yes, sir.
chances of getting recurrent infection as a cause. Maybe
Yes,
there's
sir.
some amount of embolism or even heart failure you can have being frothy sputum. So
Yes, sir.
everything is possible in the background.
Yes, yes, sir.
So what inference so far you have from this history and observation?
We are narrowed the possibility to a cardiac cause.
That's correct.
Then there is left ventricular failure
Why it is
Possibly.
ventricular, not atrial?
because the PND is present.
What is
There is-
present?
PND, sir.
No. Do you get PND in mitral stenosis?
Yes, sir, is possible.
Is it the left atria that fails or left ventricle that fails?
Left heart, sir.
Left heart means?
Sir, in mitral stenosis, there is left atria is.
That's right. So when you have PND, you can say only left heart failure.
Yes, sir. Yes, sir.
Not the left ventricular failure. Okay.
Yes, sir.
So what is the inference you draw from this history? Cardiac patient.
Yes, sir. Cardiac patient. Now,
Anything else?
presenting with any some pulmonary edema or
Pulmonary
pulmonary
edema,
arterial hypertension.
Good. So the palpitation indicates there is hyperdynamic
Yes, sir. Hyperdynamic circulation.
problem. Hyperdynamic problems are commonly seen in regurgitation lesions.
Yes, sir. Related lesion, sir.
Mitral stenosis, atrial stenosis, symptoms are not usually palpitation.
Yes, sir.
But mitral regurgitation, aortic regurgitation, they come with volume overload situation, they have got palpitation.
Yes, sir.
So possible left heart failure, I said, pulmonary hypertension, good diagnosis. Okay. So what all things you want to know in the past history?
In past history, we have to ask about any childhood infection, long-term antibiotics, any rashes present, malar rashes, any history of any cardiac infections.
Okay. Why did you bring malar rash here? Which condition you are talking about?
Sir, in systemic lupus erythematosus,
Is it the history here?
no, sir,
Why did you bring it here?
that can lead to recurrent lesions.
So we want to know whether he had rheumatic fever in the past.
Yes, sir.
Only history is there is no history of arthritis, no history of any cardiac failure, but chorea at the age of 15 lasted for months.
6 months. Yes, sir.
What do you make out of that?
In Korea, in rheumatic fever, we get Sydenham's chorea.
Does it last this long?
Sir, it usually short-term illness usually, sir.
The rheumatic chorea lasts couple of months, like this patient,
Yes,
and it does not come
yes, sir. 6
along
months.
with other features of rheumatic fever. It comes separately, alone, as isolated one.
Yes, sir.
So what is chorea?
Yes, sir. Chorea, it's an involuntary jerky movements.
Are they repetitive?
Yes, sir. Repetitive.
Non-repetitive. Chorea
Sorry, sir.
is non-repetitive,
Yes, sir.
quasi
Non-repetitive.
involuntary movement.
Yes, sir.
They are very jerky, very rapid movements.
Yes, sir.
Can you name one more condition producing chorea at a very young age?
Yes, sir.
Or
Huntington's
at any age?
chorea. Huntington's chorea.
Huntington's chorea usually occur in slightly more aged people. As it passes through generations, maybe it comes down, the age comes down, otherwise in 40s, 50s, 60s. Any
Yes,
other
sir.
the cause for chorea?
Sir.
Has that something called Wilson's disease?
Yes, sir. Wilson disease, sir. Yes, sir.
Can drugs produce chorea?
Drugs can produce, sir.
Produce chorea. So what else you want to know in this history? You asked
Other features of rheumatic fever.
Okay. You have some rash. What rash you are talking about?
Sir, in this case, we have to ask about the erythema marginatum.
What did you ask?
Sir, I asked about the malar rash, sir.
What else you ask the family history of this patient?
In family history. Family history.
Would you like to ask about her previous pregnancies? Is it important for you?
Sir.
Family history is important in the sense we would like to know whether previous pregnancies were successful, whether she went through
Yes,
heart failure, whether she had any complications. According
Yes, sir.
to
Yes, sir.
that,
Yes.
to give proper advice to this patient. The
Yes, sir.
patient going for pulmonary edema, pulmonary hypertension, he is not a fit person to become pregnant.
Yes, sir.
Okay. Personal history, what do you want to ask?
Personal history.
Is she fit to become pregnant?
No, sir.
No. So personal history must include what all precautions they have taken. Drug history, what do you want to ask?
Contraceptive. Yes, sir.
Yes.
In drug
If she
history.
takes contraceptive,
Sir, long
is it-
term. Any use of contraceptives?
how does it help you? Will it precipitate heart failure? Will it retain salt and water?
Yes, sir.
Yes. So it is no good.
Yes, sir.
Anything
Yes,
else you
sir.
would like to know the drug history?
In drug history, a long-term antibiotics intake during childhood
What for?
for prophylaxis of rheumatic fever, rheumatic heart disease,
Which drug you give?
penicillins.
Which penicillin you give for that?
Sir, benzyl penicillin.
Benzathine penicillin.
Sir, benzathine penicillin, sir.
How often you give it?
For once daily we give.
Once in 3 weeks.
Yes, sir. Once in 3 weeks.
Okay.
5 weeks.
So,
long dose.
what do you ask in the socio-economic history of this patient?
Sir, low socio-economic status.
Exactly, can you be specific about it? Who else live with this patient? If she is living alone,
Yes, sir.
she will have to do all the household works. With the patient in heart failure, that is not a good option. She cannot draw water from the well. She cannot cut wood. She cannot wash clothes, climb stairs. So you would like to know background story and advise them.
Yes, sir.
On examination, these are the findings.
Yes, sir. Pulse 90 per minute, 90 beats per minute. BP is 110/80 millimeters of mercury. JVP is not elevated. Apex in sixth space in anterior axillary line. Then systolic thrill positive in left parasternal heave is present. P2 felt in the second intercostal space. S1 is soft. A pansystolic murmur of grade 4/6 in the apex. P2 is loud. Lung basis there is crackles positive.
Percent, not positive, percent.
Yes, sir. Percent, sir. Percent.
So what do you make out? Line 1?
Sir, line 1, pulse 90 per minute. It is normal, sir.
Okay.
BP 110/80 millimeters of mercury.
Normal.
That also normal. JVP is not elevated.
What
Apex
does it
is
mean? What does it mean?
there is no right heart failure.
Okay.
Then apex in sixth space anterior axillary line. That
So what-
indicates there is cardiomegaly.
Anything else?
Then there is pushed down and out, sir.
What does it mean?
That is eccentric hypertrophy.
So down and out indicates that there is
Volume overload.
left ventricular
Yes, sir. Left ventricular hypertrophy, sir. Yes, sir.
hypertrophy. And the apex in this case was forceful in nature.
Yes, sir.
What does it mean to you?
That is, there is regurgitant lesion, probably regurgitant lesion, volume is high volume.
Volume overloaded situation.
Yes, sir. Yes, sir.
Volume overload situation. What is the forceful apex?
Forceful apex is it elevate
The palpating finger above the
Yes, sir.
adjoining ribs, but ill sustained.
Yes, sir. Is sustained, sir.
So what can you name some situations where it is seen?
Sir, it is seen in aortic regurgitation, mitral regurgitation.
Fine. And then there is a systolic thrill.
Yes, sir. Then systolic thrill is present. The left parasternal heave is also present.
Yes, over the apex, there is a systolic thrill. What does it mean to you?
There is turbulence of flow, blood flow.
Which are the conditions where you get systolic thrill over the apex?
In mitral regurgitation, we get.
So I can say like that.
Yes,
We can conclude that this patient has got mitral regurgitation with the left
Yes, sir.
ventricular hypertrophy, volume overload situations. Okay.
Yes, sir.
Come to the next part of the story.
Then we have left parasternal heave that
What
indicates
does it mean?
right ventricular hypertrophy.
Right ventricular hypertrophy. Okay.
Yes.
What else?
Then we have P2 felt in the second left intercostal space.
What does it mean?
That is palpable P2.
Palpable P2 indicates what?
Pulmonary arterial hypertension.
Pulmonary hypertension is present. Then auscultation.
On auscultation, S1 is soft. Then a pansystolic murmur of grade 4/6 in the apex.
Okay.
That is
What are the situations where you have soft S1?
In soft S1 is seen in mitral regurgitation, sir.
Any other?
any other?
Wherever there's a bradycardia, you can have softest one.
Yes, sir. Bradycardia, sir.
The P2 is loud.
Yes, sir. P2 is loud, sir.
When do you say P2 is loud?
P2, and when we are auscultating at the aortic area, we are getting A2 and P2 at same intensity. That indicate P2 is loud.
So P2 is commonly heard only in the pulmonary area. When elsewhere, same intensity you call it as loud.
Loud.
Okay, next sentence.
Then a pansystolic murmur of grade 4/6 in the apex.
Yes, what does it mean?
That also indicating mitral regurgitation, sir.
Right. Okay.
Then lung basis bilaterally crackles present. That indicate pulmonary edema.
Pulmonary edema. So what is the diagnosis so far?
My diagnosis is valvular heart disease, mitral regurgitation with complicating with this pulmonary arterial hypertension, and now there is pulmonary edema also.
Etiology being
rheumatic heart disease.
So you have a rheumatic heart disease, mitral regurgitation, pulmonary hypertension, heart failure. Is it a mild mitral regurgitation or severe mitral regurgitation?
Yes, sir. It is severe, sir. Severe, because
and no endocarditis,
no endocarditis,
no rheumatic activity, and no evidence of atrial fibrillation. So what are the signs of severe MR?
Severe MR, there will be thrill will be present.
Okay.
Then intensity of the murmur will be high.
So very soft S1.
Yes, sir. Very soft S1.
Displaced apex means there's cardiomegaly and impact on the heart.
Yes, sir.
It cannot be mild.
Yes, sir.
Thrill.
Yes, sir.
Commonly,
yes,
when you have regurgitation of blood from the ventricle, it goes to the atria.
Yes, sir.
And it comes back across the mitral wall. There will be more blood across mitral wall. So it can produce a functional mid-diastolic murmur.
Yes, sir. Yes, sir.
Okay, that can also be an evidence of severity.
Yes, sir.
And widely split S2. How does it
happen
like that?
Because of the pulmonary arterial hypertension, the P2 will be late.
That's right. When the ventricle pumps blood,
yes, sir.
majority of the stroke volume, commonly for a normal person, goes to the aorta.
Yes, sir.
But in a severe case, majority of the blood is emptied into atria. Early it is going to aorta.
Yes, sir.
So obviously it comes early.
Yes, sir. A2 will be early, sir.
Early, okay. So also this patient has got evidence of pulmonary hypertension and there's pulmonary congestion. What about S3? S3 commonly occurs in patients with mitral regurgitation, and commonly it does not indicate severity. It only indicates rapid ventricular filling.
Yes, sir.
But if all other signs are present, then only S3 is taken into consideration to decide the severity. So, in clinical practice, what are the other causes of pansystolic murmur? Before we go into that, what is by pansystolic?
Pansystolic means it is full start with S1 and ends with S2.
That's right. It must touch the S2. So what are the situations where you can have a murmur of that type?
We get in ventricular septal defect, then mitral regurgitation and tricuspid regurgitation. Then mitral valve.
So we have tricuspid regurgitation, VSD and mitral regurgitation. So close differential diagnosis of this will be tricuspid regurgitation versus
Yes, sir.
mitral regurgitation. So how do you differentiate
Yes, sir.
between the two?
In TR, tricuspid regurgitation, there will be Carvalho sign.
Right?
TR murmur will be based on inspiration,
Right?
and there will be liver may be pulsatile liver may be seen. Then
Good.
JVP will be increased.
Good.
Then features of right heart failure may be present. Edema will be there. Ascites can be there.
So let us go to the 6 basic steps to differentiate between the two. In tricuspid regurgitation, pulse do not show much change, but in severe mitral regurgitation, you may get a increased volume of the pulse.
Yes, sir.
And JVP is very classical for tricuspid regurgitation. Very classical
Yes, sir.
V waves.
Yes, sir.
Thrill is very classical for mitral regurgitation, and it is heard over the apex.
Yes, sir.
Thrill is rare in tricuspid regurgitation, and if at all occurs, it occurs in the lower sternal area.
Yes, sir.
Apex beat is displaced down and out and forceful in case of mitral regurgitation, but not so in case of tricuspid. The murmur of mitral regurgitation is commonly heard over the apex, conducted to the axilla or to the base of the heart, but murmur of tricuspid regurgitation is localized to the tricuspid area, not elsewhere,
Yes, sir.
and it increases, as you correctly said, with inspiration. And
Yes,
liver will be pulsatile in tricuspid regurgitation, not so in mitral regurgitation. How will you elicit pulsatile liver?
By sir, using both hands.
Bimanual palpation.
Over the
Very good.
liver. Bimanual palpation, sir.
How are you going to treat this patient?
In treatment, we have medical management is not much useful, sir. We have investigations and treatment. In investigation, we have to take an echocardiogram to confirm this diagnosis, and for the severity assessment and all.
Okay.
Hello, sir.
So we have to treat this patient pulmonary edema for time being.
Sir, for pulmonary edema, we can give furosemide. 40 mg can be given, sir.
And some vasodilators may have to be given. And you have to tide over the crisis. You should also plan for some salt restriction, activity restriction, and plan for some prophylaxis for rheumatic fever. So,
Yes, sir.
you go for investigation first. ECG should show left ventricular hypertrophy, left atrial hypertrophy. X-ray may show cardiomegaly, and
Yes, sir.
you may see left ventricular hypertrophy, and features of pulmonary edema may be present in this case.
Yes, sir.
The pulmonary artery may be dilated, left atrial appendage may be bulging, left ventricular hypertrophy may be obvious, upper lobe veins may be prominent, there will be batwing appearance, early B line, pleural effusion, and so on. Echocardiography is a must.
Yes, sir.
And if you are planning for surgery, then you have to go for angiography.
Yes, sir.
If you suspect that mitral regurgitation is due to coronary artery disease, again, you have to go for an angiogram. So, commonly the mitral regurgitation patients go a long time, years together, without any confusion or complaint. They are symptomatic.
Yes, sir.
But once they become symptomatic, that's a different story altogether. So how do you plan for surgery?
Sir, in a young patient, we can do. Yes, sir.
Class 3 or class 4?
We are assessing the. Sir, this patient is in class 3.
Right?
So we can go for valve repair.
Class 3 or class 4 is a indication for surgery. In spite of
Yes, sir.
optimum medical therapy, patient not improving, again is a patient for surgery. Asymptomatic patients, commonly we don't do surgery, and you follow up every 6 months with echocardiogram, that's all. And
Yes,
if
sir.
they are asymptomatic, we find that
Yes, sir.
ejection fraction has gone down to less than 60%.
Yes, sir.
What is ejection
Yes,
fraction?
sir. Ejection fraction mean the stroke volume divided by end diastolic volume.
So, stroke volume percentage.
Yes, sir. Stroke volume percentage, sir.
Okay, so your stroke volume, heart is pumping only 60%. It's expected.
Yes, sir.
And that is
Yes, sir.
for surgery, even if they are asymptomatic.
Yes, sir.
Or end systolic diameter is more than 45. What's by end systolic diameter? What do you mean by that?
At the end of systole, the diameter of the mitral valve.
No, diameter of the ventricle.
So,
You're talking about the diameter of the ventricle. In other words, when the heart is pumping, left ventricle is pumping, you know whether there is adequate amount of contraction of the ventricular muscle. You are measuring this volume. If there is no adequate pumping, you will find that end diastolic diameter remains high.
Yes, sir.
This is an indirect way of assessing the severity.
Yes, sir.
Okay, let's go to some questions to JR. How do you manage atrial fibrillation?
Hello?
Your answer,
Yes, sir.
please. Your answer, please.
It's atrial fibrillation. We have to anticoagulate the patient since there is a possibility of formation of thrombus in the atrium.
Anything else you'll do?
The rate control of the patient.
Rate control. Okay. When does the murmur radiate to the parasternal area in mitral regurgitation?
If there is a mitral valve prolapse.
When the posterior cusp is affected, the murmur radiates to the sternal area and anterior cuspis goes to the axilla. Why you are planning coronary angiography in this patient?
Since there is a left ventricular hypertrophy, then there is a possibility of infarction.
Oh, the
Also,
two possibilities are there. Okay, carry on.
Also, a mitral regurgitation may be a result of myocardial infarction.
That's right. When you are planning for surgery, up to a certain age, there's a chance that the patient also has got coronary and artery disease, even if it's remaining silent. So you have to correct it simultaneously, otherwise your result will not be good.
Yes, sir.
What are you going to look for in echocardiogram?
We have to look at the LV function.
One, as evident.
Then we have to look at the mitral valvular area.
Okay, you have to study the mitral valve area, whether it's repairable or not. But
Yes.
in the function of the ventricle is assessed by ejection fraction
Yes,
and
sir.
left ventricular and systolic diameter, which are the two criteria for deciding indication for surgery. So that's
Sorry.
what you're looking for every 6 months follow-up of this patient to know whether we have to go for surgery or not.
Okay,
So
sir.
if the patient's first heart sound is loud, what are your explanations?
Associated mitral stenosis could be there.
One. Any other possibility?
Possibility of a vegetation.
When you have mitral regurgitation with a preserved S1, you must
Yes,
think it is non-valvular type of mitral regurgitation. Classical
Okay, sir.
example is MVP.
Okay, sir.
MVP you have. So when the valve cusp is affected, you have muffled S1. When the
Okay, sir.
non-valvular problems come, there is this issue. Can you tell some causes for mitral regurgitation?
Rheumatic heart disease,
That's common. Okay.
commonest. Then post a mitral myocardial infarction. There could be post myocardial infarction sequelae. There could be rupture of the chordae tendineae,
Right.
dilated cardiomyopathy.
Right. MVP.
Yes, mitral valve prolapse.
MVP is there. Cardiomyopathy is there. In
Yes.
old people, what are the common cause? Very old people, 80 years, 90 years.
Calcification of the mitral valve.
Idiopathic calcification. Can you get functional mitral regurgitation?
In
Functional mitral regurgitation occurs when the heart as such is dilated because of some other reason.
okay. Like,
The valve ring is dilated.
yes, sir.
It will be reversible as you control the heart rate and control the heart failure.
Okay,
The
sir.
mitral regurgitation will become less. It's called functional. Can you tell some causes for acute mitral regurgitation?
Myocardial infarction causing rupture of the chordae tendineae.
Yes. The rupture of cardiac valve can also occur in infective endocarditis
Yes, infected.
or people who have trauma,
Okay,
some
sir.
accident and so on. So how do they present?
Acute palpitation, breathlessness.
When the acute mitral valve undergoes regurgitation abruptly, the left artery is not yet ready to face that scenario quickly.
Okay, sir.
So the pressure is going back to the
Pulmonary or
pulmonary veins and
veins and
they come with pulmonary edema.
okay, sir.
That's an emergency. Unlike in a rheumatic heart disease where there's plenty of time for the heart and pulmonary circulation to adjust, subsequently they go for heart failure.
Okay, sir.
What does S4 indicate in mitral regurgitation?
The left ventricular status in S4 is present in left ventricular failure.
Okay. S4 indicates that the atria is contracting against a non-compliant
Ventricle.
left ventricle. The S4 also indicate that there is no atrial fibrillation. Why?
Atria is contracting.
That is
And
contracting.
adequate.
That's true. Now, before we conclude, tell some rare causes for mitral regurgitation. We should not consider the first possibility when our patient comes, but rare cause.
Cardiomyopathy.
That's common. Cardiomyopathy is common. Can you think about tall people?
Marfan syndrome.
Yes. Can you think somebody with the blue eyes?
Osteogenesis imperfecta.
Yes. Can you think somebody with joint disease?
Ehlers-Danlos syndrome.
Pseudoxanthoma elasticum.
Okay, sir.
Do you get mitral regurgitation in rheumatoid arthritis and SLE?
Due to the vegetation.
Yes, you can have. You can have mitral regurgitation in both these conditions. So, this patient under discussion was having mitral regurgitation with a past history of chorea. So, we can conclude that possibly it is a case of rheumatic heart disease. Now, can you tell me some causes for chorea?
Rheumatic heart disease, Huntington's chorea, then can be
Not rheumatic heart disease, rheumatic fever.
yes, rheumatic fever. Sorry.
Then
Huntington's chorea. Then as a syndopatoxicity.
Syndotoxicity, okay, drug induced, yes.
Drug-induced
Okay, right.
Okay. Wilson's disease.
Wilson's disease, yes.
Then hereditary chorea.
Can SLE produce chorea? Can EPLA produce chorea? What is chorea gravidarum?
Yes, sir.
Tell about that.
Yes, sir. Yes, sir.
So what will be treatment for chorea basically? How do you stop these involuntary movements? Give haloperidol.
Sir.
Haloperidol.
Okay, sir.
So once you get history of rheumatic chorea, do you give them prophylaxis?
Prophylaxis for rheumatic
Fever.
rheumatic fever prophylaxis for 18 years or till the 10 years after the disease.
That's okay.
Whichever
That's
is.
okay. So the point is, chorea doesn't come along with arthritis. It comes
Yes.
separately and it continues for long time.